Great. So before I start anything, the first thing that I should do is to introduce myself with you. And because I will be your coordinator for your AMC clinical exam preparation for most of the classes. And also there will be a couple of other doctors who will also come and introduce themselves with you during their classes. So my name is Dr. Arshan. I am practicing in Australia at the moment, and I have experience in both hospital setting, GP settings. So I have almost all idea of this Australian health system. So I can guide you in any of the two directions. That's the commonest directions in here. And also you'll get a little bit of idea about the Australian health system pathways. We are planning to just do a class just in 2 weeks time, likely not the next Saturday, the following Saturday, likely it should be 26th of November. 26th of November, we should take a class on the Australian health system, registration pathways, job searching, and a lot of other stuff. So we will go through those things at that class, so no problem on that. And I have been to I have been with this Australian health system for a long time now, and also this clinical course and MCQ course is a part of my hobby also at the moment, just to make sure that you guys also have someone to look up to, and you can ask questions because the experience matters a lot. Because when you do something for a long time, you know everything about it, and that experience can help you because you are still in the initial stage of it. Good that you already passed your MCQ. Now once clinical is done, you are on the way to your dream to start working in Australia. And many of you are already working, I know. So that's also good. You just need to do this clinical exam as part of your registration. So whatever you are at the moment, whatever position you are at the moment, you are here because you need to pass AMC clinical exam. And first aid AMC clinical is one of the best clinical exam preparation course that you can ever see. We have almost everything that you need to pass this exam. And it's not just saying that I'm just saying because we are doing this course. It's not about that, because you can look into our Facebook group and see that every month almost we can always 6 to 8 peoples are passing in every month. So you understand that how good it is, because previously if you would look into anywhere, you would not get even 1 or 2 people passing in one month. On the contrary, if you look into our success, you can see that everyone, if I say everyone, that's not right. If most of the candidate who is appearing the exam, they are passing in their first attempt. So that's how it is. So obviously we are doing something different from others, and there's the reason why candidates are passing the exam in their first attempt. And it's not only us, our candidates also do a lot of hard work. And during this 5 months course, we are going to help you in each and every possible way. And eventually, if you follow our guideline, I am hopeful that you will pass this exam. Passing this exam, it's never ever very easy, because if it was easy, everyone would pass the exam. It is hard, and it should be hard because it is something which will lead you to start working in Australia. Not everyone will be filtered initially, and this is a filtering for the purpose of giving a greater clinical experience, greater patient support in here, which Australian system usually works a lot about that. They want to filter you so that the only the best come out of it, and that's the reason why the passing rate is never ever very high, and it's never going to be high. So that means that you will have to be one of the best in your exam to pass this thing. So in that case, obviously we have every guideline that you need, and if you follow it, I'm very hopeful that it should be fine, and most likely you will pass the exam in your first attempt. That's what you really want, right? You don't want to linger this exam a long time. We will come to the preparation later on, that how to take a good preparation, how you should focus on your steady body, how to do role play, each and everything we will go through throughout the course, and also a little bit more in our orientation session. Tonight is not about orientation, it's about our trial class, so that you understand how we take session, so that you also get a feeling that is this right for you. Okay, so and also you are going to get 2 weeks free session from us. So that 2 weeks free session is enough for you to understand if this course is right for you. All right, so lots of jib jab. Let's start our session. So AMC clinical exam. Nowadays, there are two methods of clinical exam, which means you go for either a face-to-face exam or an online exam. During the COVID era, the online exam got the popularity. But now the COVID thing is getting a little bit more flexible. Face-to-face exam is more preferred and more easily you can get registered rather than online exam. It is actually very hard to get into online exam these days because the number of online exam is very low. So in my experience, I would always say that if you are living in Australia, don't even think about online exam. Go for the face to face because getting the exam date is easy, and also it's not very hard to pass the exam. But if you're out of Australia and you don't have anyone who can help you with the visa, then yes, online would be a very good alternative for it, because getting the visa, coming in here, those things are not also very easy. So online is good for you if you are not in Australia. If you're in Australia or you have way to come into Australia, face to face is much better. Okay. But throughout the course, we will help you with the both face to face and online, so that you get an idea of the both mode of exam. And it's not very different. It's a different thing is that face to face you need to come in here, and the only center in here is the Melbourne Center. That's that's the only center where we are getting the AMC clinical exam currently. And the online exam means you can appear the exam from anywhere in the world. You just need a good laptop and a good internet connection, and you're good. Okay. So for face to face or online, we will go through a very detailed explanation of online examination during our orientation class, not for today. But for face to face, let me give you an idea so that you have something in your head that how this is going to work for you. Because many of you are here just after passing your AMC MCQ exam and you don't have any idea. And I know that some of you are here who already might be you already appeared an exam, or you are in the middle of your preparation. So for those, it's not new because you are already aware of it. But for who are new in here, face-to-face exam means that you need to go to the exam center. And when you go to the exam center, there will be some cadet they say. So there will be someone who will receive you, and then you will hop up in a elevator, and then you will go to the exam center. When you go to the exam center, they will give you some locker to put your stuffs. The only thing that you can take into your exam is your stethoscope, nothing else, not even your watch. So you can take your stethoscope, and then they will give you a little bit of briefing about how this exam is going to happen. They will also assign you a ID card that you will have to hang on your neck, and that ID card will have your name and also the first station that you are going to appear. So there are 20 stations, or you can say 20 rooms in total, and among those 20 rooms, sorry, so among those 20 rooms, 16 are your exam stations and 4 of them are rest station. So 16 is your exam stations and 4 rest station. That's your 20 rooms that you will be there. So each room will be separate, and everyone who is appearing the exam on your date, They will be assigned one room and then you will just rotate around. So among these 16 stations, two of them will be a non-scored or pilot station, and 14 of them will be a scored station. And like your AMC MCQ exam, you will never know which one is your pilot and which one is a scored until you get your exam result back. So among these 14 station, if you can pass 10 station out of 14, you pass the exam. And that's what you actually wish for. If you can pass only 10 stations out of 14, your all the hard work is paid off. And trust me, that's a dream to pass the exam in the first attempt. And if you can do that, it's really you have saved a lot of time, a lot of energy, and a lot of life expectancy because preparing for this kind of exam makes you exhausted. So if you do something like that, you should prepare in a very concise, well organized way so that you don't waste too much time roaming around and listening to a lot of things from a lot of people. And then you just become confused and waste your time, which you don't need to do. So the rest stations are just you just take a rest. Usually we can see that after 4 station, you go into a resting room where you can drink some water, nothing else. And you can pray for your next stations to happen like to have it nice and well. The main issue in the rest station that you keep on thinking about what you have done wrong in those past 4 sessions. Okay. So my my recommendation is not to think about what happened in the past 4 sessions, is to mainly just focus on drinking a lot of water, maybe pray to you wherever you are praying, and also just think that you are going to do it. So each of these stations are in 10-minute duration. Same with the rest station, those are also 10-minute duration. So out of this 10 minute, 2 minute you will be outside the room and there will be a monitor on the top of the door, and that will give your exam station or the case. So whatever case you are going to get, that case will be on a monitor outside the door of your station. You will get 2 minute time in the outside to read that task and think a little bit that how you're going to take a history, how you're going to do diagnosis, management. They always give you a task that take history, do physical examination, do investigation, talk about management. So whatever task is given, just think about what you are going to do in that 2 minute time. You can't write anything in that 2 minute time. Once your 2 minute is done, a bell will be rung, and then you will go inside the room. The examiner will be there who will greet you and ask you that can you please show your ID. You will show your ID. Examiner will check that if your ID match with your match with your data. And once it's done, then examiner will say like this is your patient John. You can start. So your patient will be sitting or lying on a couch or on a chair, and then you go in and you start your examination. So that inside your room, you will get 8 minutes to finish your task. And in that 8 minute time, they will give you a pen and paper to write. If you want to write their name, you can write there. If you want to write a lot of things, you can do it there. But we always recommend not to write a lot of things because it just wastes a lot of time. Okay. So that's your how this exam is going to happen. So each of the stations will be like this, and you will rotate around and you will finish your 16 station. And that day is done. And then you will wait for your exam. Usually 2 to 3 weeks, you get your exam result. Okay. Any question on the exam part, guys? Did you guys understand what I said? Yes, online exam also have rest stations. You can write your task on a paper. That's right, Dr. Aisha. If you think that you will forget about it, you can do that. There is no problem writing on the paper, but you will just waste a lot of time. So it's a good idea that remember the task. Yes, for physical examination, most of the time there will be a bed there. In online exam, yes, you can also write things because they will allow you to keep something on the desk. You can keep a white paper and a pen, but you can't write it in the 2 minute outside, but in the 8 minute inside, you can write it. Yes, there is a timer, but you will never see the timer. That means there is no clock inside the room. You will not be able to see that. There will be only bell. So whenever bell rings, your time is up. You straight go out of that room and you start your next station. So that's pretty much a little bit idea about this exam. We will discuss a lot about this in our orientation session after 2 weeks free sessions is done. So once you are going to join the course, then we have our orientation session. So that's usually after 2 weeks free session. So 2 weeks free session is done. We start our orientation class, and then you can go through our. We will go through each and every part of this exam, like how the online exam will happen, how the face-to-face will happen. So that will be a detailed class on that first. Okay. So let's start with the psychosocial history. At the end of our tonight's session, we will go through what are the outline of this course. That means the course details and everything. And we'll discuss a little bit about this course so that you have an idea. Okay. So let's start with the psychiatric history. Psychiatry is one of the most important topic for your exam. And honestly speaking, if your psychiatry approach is good, it actually means that your whole approach is very good. And the exam has a way to find it out that you are a good gentle person or you are just a mean person. It's very easy to find out through the psychiatric cases, because how you deal with a psychiatric patient shows yourself. And a lot of candidates, because of the exam pressure and because they lose their cool, they just lose it in the exam. They show their inner anger, inner nervousness to the patient, which you can't do. The approach is one of the most important pillar of passing this exam. If you want to pass clinical exam, your approach has to be right. It cannot be someone who is just there to talk and shower all the knowledge on a patient. It's never ever showering the knowledge. It's never ever about how much knowledgeable doctor you are. It's all about how better you can communicate with a patient and if that patient likes your approach. If that patient says no, I don't like that doctor, you are failed immediately, even if you have done everything in that exam. So there is a saying that normally when you finish your exam, you get out of the door, and then examiner asks the role player that did you like this doctor? And if that role player say no, even if you have done everything right, the examiner can fail you because of your approach. So that's a very important thing to remember, that this exam is not just about knowledge, not just about finishing every task. It's about as a whole, how good doctor you are, how much gentle you are, how much professional you are. All this matters in here. That's the area where most of the candidates get failed, because they are first time candidate, they are appearing this exam, they are already very nervous and they are already aware that more than half of the candidate will fail the exam. So all of these things put a huge pressure on their mind, and they forget about their gentle approach that they used to do with a patient, but because of the exam pressure they just don't do it. And that's how most of the candidates fail their exam. But if I ask any of our candidates that how was your approach marking in your exam, that was always the best. Our candidates even pass globally just because of their approach. Rather, like they might miss couple of key steps, but still they end up passing the exam because of their approach. So we show how to make your approach nice and good so that anyone who is taking the exam likes your approach. Okay. So we would start with a psychosocial history now. If you guys don't understand at any point, don't hesitate to ask me multiple times. And that's how you learn. You make mistake, and then we show you the mistake, and you fix it. If you can do that, you're in the right path. All right. So psychosocial history is the basic of taking a psychiatric history. Almost every psychiatric question that you are going to get in your exam, which is most of the time one or two, most of the cases you will need the psychosocial history. And I think like for those of you who are already going through our Facebook course detail, you already know how we take the session. We make it very concise. Our history is very like maybe we have for psychiatry we have only one history format, and that history format you will use in every psychiatric question. Same with any other medicine, pediatrics, we have very small amount of format for history, and you just use that format for almost every cases. So that's called cluster-wise approach, which we have done it, and it's very, very easy for the candidates to remember it. Because if you need to remember 300 cases all separately, it's not possible. You will make mistake. But if you just make, let's say, 30 to 50 cases as a cluster, and you can use that 30 case for 300 cases, that's where your preparation becomes very nice and good. So that's what we normally do in our course. So you will learn how to do that, and you will also learn how to use those format so that your preparation becomes short, which is very important. So starting with the psychiatric history involves, first of all, giving a good confidentiality to a patient. It's a sensitive thing to a person that you are asking for that are you a crazy or are you depressed? Are you having mental breakdown? You can say that this is one of the most sensitive and personal information that any person can have. So you are asking those questions from a person who needs your trust, which means that you need to make that person feel safe with you. And if you can do that, only that time they will start opening it up. And if a patient does not open up with you, you are whatever you are doing, it's not right. You'll need to create that environment for that person so that he or she can talk anything that's going on in their head. Whatever bad or good it is, they should be very comfortable with you. And the psychiatry is something like that. You make the environment, you create a non-judgmental area so that patient can open up very frankly. And if you just say one single line of confidentiality, which is the conventional approach you will see in almost every courses, they are just asking you to do this. Like there is conventional approach, and then there is this alternative approach that I like. I ask everyone to follow this because that makes that environment, that makes that patient feel that yes, this doctor is nice, I can talk to him. So when you start with a psychosocial history, let's say one patient is coming to you because he's feeling very low. So you'll need to take history from that patient. And that means you have to take a psychosocial history. So how you are going to start with a conventional approach and how you are going to start in an alternative approach. So the conventional approach will be something like this. Hi, this is Dr. Arsham. I'm one of the doctor here. It's very nice to meet you. I understand from the notes that you're feeling very low. I'm very sorry to hear that. Will you please tell me what's going on? But let me assure you that whatever we are going to talk today, it is between you and me unless it is harmful to you or others. So that's the conventional approach. The initial approach is good because we normally do that. But let's say that rather than doing this, we do like this. So you say, hi, John, this is Dr. Arsha. I'm one of the GP here today. It's very nice to meet you. I can see from the notes that you are feeling very sad. John, I'm really sorry to hear that, but I want you to know that I am here to help you. You can tell me what's making you really sad and stressed. There is nothing judgmental here. You can feel comfortable to talk to me. And I can assure you that this is confidential between you and me. And you can't say anything to me which will make me feel bad about you or make me feel judgment just about you. There is nothing you need to be embarrassed about. I'll be here with you unless you are ready to talk. Okay? See that you created an environment where patient actually thinks, no, that this doctor actually care for me, right? So if I give it again, so keep it in your head so that you can use this line everywhere where you need to give confidentiality to a patient. So hi John, this is Dr. Arshan. I'm one of the GP here. It's very nice to meet you. I can see from the notes that you are really sad and stressed. I'm very sorry to hear that. But I want you to know that I'm here to help you and you can tell me whatever making you really stressed and sad. There is nothing to be uncomfortable about, and I'm not here to judge you or make you feel embarrassed. Trust me, there is a lot of patients who come here with this similar complaint. But you need to understand that I'm here so that I can help you to go through this. And I also want you to know that whatever you are going to say to me, it is confidential between you and me. I will be here with you until you are ready to talk. So if you say something like that, there is no depressed patient in the world who will not open up with you. Trust me, they will. They have to. Once you do that, then you start going into the detail. Many times, if it's a depressed patient, they might not even say anything, even after giving a good initial confidentiality statement. If patient does not say anything even after you have given this confidentiality statement, you can just start asking questions like, will you please tell me your mood? Then they start talking. Okay. Otherwise, you can ask the patient, so John, will you please tell me a little bit more about what's going on? And many times patient will just say that, yes, doctor, this happened, and that's why I'm feeling very sad and stressed. Then you appreciate the patient. I really appreciate John for opening up with me. So please tell me about your mood these days. So the first question that you are asking is about the mood to find out what they say. Is this patient's mood is low or high? So if patient says low, there are a couple of questions that we can ask. We ask that at any times, do you feel high sometimes? So why we are asking that, do you feel high sometimes? Because we are trying to rule out the possibility of bipolar disorder. Because now might be patient in a depression stage of bipolar. Sometime maybe he or she gets mania or hypomanic states. So if a patient say low, sometimes we can ask that, do you feel very high sometimes, or do you feel unusually high sometimes? After mood, the next question is, how is your sleep and appetite? If patient said, no, I'm not getting much sleep, then we have some detailed question about it. We'll go to that later on when we ask some sleeping disorder question. But if I give you an idea about the sleeping questions, it mainly we ask that is it an initial insomnia, or is it early morning waking up, or is it a nightmare, or is it multiple broken sleep at night? So we ask the patient, like, do you have difficulty falling asleep? If patient have difficulty falling asleep, that suggests anxiety. Or do you get up early in the morning and you have difficulty to fall asleep? Early morning waking up and then difficulty to fall asleep suggests depression. Or do you get multiple broken sleep at night? If patients say yes, then do you also get some nightmare? Getting multiple broken sleep and nightmare suggests the possibility of post-traumatic stress disorder or PTSD. Okay, so those are our sleep-related questions. Only if a patient having problem, then we ask it. So we asked about mood, sleep, and appetite. Then we go for suicidal risk question. So we ask the patient that, do you think that life is worth living? If patient says no, then you say that, do you have any passing thoughts of harming yourself or others? Now, if patient say yes, doctor, I have passing thoughts of harming myself, then we ask these two questions. Do you have any definitive plan to commit suicide? Have you have you had any previous attempt? Do you have access to any weapon? So that's a couple of questions only we will ask if patients say that their life is not worth living or they are having some suicidal thoughts. So that's suicidal risk. It's very, very important not to miss suicidal question in any psychiatric history. Once you have done the mood, sleep, appetite, and suicidal risk question, then you go for some other psychiatric questions, which is hallucination and delusion. Okay. For hallucination and delusion, because this can make some people feel like, why this doctor is asking me these crazy questions. So we just ask initially that, John, now I am going to ask you some screening question that might seem quite strange to you. Is it all right with you? Yes, doctor. So for hallucination, we ask that, do you see, feel, or hear things that others don't? So see means visual hallucination, feel means tactile hallucination, and hearing means auditory hallucination. So one question is enough. And this hallucination is part of perception in MSc question. We will come to the MSc question later on, but perceptual disturbance is all that we call it as a hallucination. After hallucination question, you go for delusion. For delusion, we follow this mnemonic RCGGP. So delusion of reference, delusion of control, delusion of guilt, delusion of grandiosity, and delusion of persecution or paranoid delusion. So delusion of reference, control, guilt, grandiosity, and paranoid or persecutory delusion. So for persecutory or paranoid delusion, the question that you're going to ask is that, do you think someone is spying on you or trying to harm you? For control, do you think someone is controlling you? For delusion of reference, do you think people are talking about you? The delusion of reference patient will say to you that everyone in the street is talking about me. So that's some things that we call as delusion of reference. Do you think you are guilty about something? And do you think you have some special power? Having a special power, usually delusion of grandiosity. So delusion of grandiosity is a feature of mania most of the time, but you can also get it in schizophrenia. Delusion of guilt is a feature of depression. Delusion of reference, delusion of control, delusion of persecution, these are usually you will be finding in schizophrenia. All right. So these are very important question, and you most of the time in the exam you get some positive findings from here. And delusion is the part of thought content of MSc. There are some other delusional question, which is thought insertion, thought withdrawal, and thought broadcasting. So when you finish your RCGGP question, then you can ask the patient that do you think someone is inserting or withdrawing thoughts from your mind? Do you think your thoughts are being broadcasted in TV or radio? So if a patient says, yes, TV newspaper has always some news for me, that's the time you will be thinking that they might be having a thought broadcasting. And if patient says, yes, that some armed force or some MI people, like a Mission Impossible people, are inserting thoughts in my head. So then you think that it's a delusion, it's a thought insertion, which is also a part of thought content in case of your MSc question. So these are the main questions that you can't forget in a patient who might have a schizophrenia. All right. Now, obviously, if you by the look of the case, you will know that if it is a schizophrenia case or it's a depression case. For a depression case, delusion of guilt is must. But for a schizophrenia case, delusion of guilt is not important. So you can even forget about asking this question. Okay. After you have done your delusion question, then you ask a couple of other MSc questions, which is insight, judgment, cognition. So insight, judgment, cognition. For insight, you just ask one question. Do you think you need some medical help? If patient says, no, doctor, I don't need any medical help, that suggests loss of insight, which you can find in a schizophrenia patient. Then judgment, let's say there is a fire in this room. What are you going to do? In case of a patient who is suicidal, they can say, oh, I will just stay here so that I can die. That's a suicidal patient. Or some patient can say that I will not do anything because I am the messenger of God. So God will protect me from fire. So that's another case which is schizophrenia. So it depends that you can get impaired judgment in any of this scenario. Then there is cognition. Cognition we always ask in terms of place, person, okay, and time. So time, place, and person. So we ask the patient, do you know where are you at the moment? Do you know what is the date today? And do you know who I am? So that's the time, that's the place, and there's the person. So time, place, person, orientation is important part of mental status exam. So that's your cognition. So you have asked about insight, judgment, cognition. Then you go for heads, SADMA, past medical history, ruling out organic cause, and family history. And that will be your finishing of this history. So what is heads and SADMA? Before I go there, do you guys are you guys understanding me? Any questions so far? Good. So heads. So heads is another important part of MSc or any psychosocial history. So in the heads, that's a mnemonic for some of the important question that you ask. So H for home situation, E for employment or education, A for activity, D for you can remember diet, drugs, S for social support, and another is sometimes we also ask about sexual intercourse, we ask about stress. So all get covered with these two S. But we don't need to go through all of these heads question. We just ask, how is your home situation? Or we can say that, who do you live with at home? How is the home situation? Are you a happy family? Is there any stress going on at home? Do you do any work? Any stress at work? And do you have enough support? That will give you an idea about the perspective of a person life. Because if someone is stressed at home or work, that will obviously impact their mental health. So that's why we ask this heads question. So heads for home situation, employment or education, A for activity, D for, you can remember, diet or drugs, S for stress, sexual life, and support. Then SADMA. For SADMA, mainly we ask about smoking alcohol. We can ask about any recreational drugs. We can ask about medication allergies. So only ask in here that, do you smoke or drink alcohol? Any other recreational drugs? Any other past medical or mental illness? Any family history of mental illness? We also sometimes try to rule out any organic cause which can mimic the psychiatric problem, which means normally we try to rule out any possibility of hypothyroidism, recent head injury, or any kind of flu-like illness, which also can mimic with the psychiatric cases. So any change in your weather preference recently? So thyroid patient always have like, if hypothyroid, they always feel very cold, even if it's a hot weather. So we ask the patient, do you have any recent change in your weather preference? Any recent head injury? Any flu-like illness? And that's how you finish your psychosocial history. It's a long history, right? And you might not, you might think that how I am going to finish all of it in 8 minute time. Well, if you do a lot of role play, you will be able to do it because everyone is doing it. Okay. And also we will show you how to cut short the history according to the task. Okay. But this is usually the format of psychosocial history that you need to remember. So to give you a summary of psychosocial history, first we give the confidentiality statement. Then we ask about mood, sleep, and appetite, suicidal risk, then hallucination delusion, inside cognition judgment, heads, SADMA, past medical history, family history, and organic cause. So that's a format that you will keep in your head. You don't need to even remember anything else rather than this format. Now, many times you will get a question like this, that take psychosocial history from the patient and present MSc to the examiner. So this presentation of MSc means mental status examination. So mental status examination, if you need to present it to the examiner, you need to follow this aseptic J3R format. So what is this aseptic J3R? So aseptic, A for appearance and behavior, S for speech, E for emotion. And emotion has two things, mood and affect. We will come to that point later on. Then P for perception, T for thought form, another T for thought content, insight, cognition, judgment. Then 3R is one is risk, rapport, and reliability. Each and everything we are going to discuss now. You already have asked a lot of this aseptic J3R in your psychosocial history. Okay, so moving on, what is this aseptic J3R? So aseptic J3R is a way to remember that how to present MSc to an examiner. So sometimes you can even write this aseptic J3R on a paper in front of you and just write the findings of this, that whatever you are getting it from the patient. When you present MSc to an examiner, This is the format that you are going to use. So first you say that, dear examiner, I would like to present the mental state examination of my patient, Mike, a 35-year-old patient found by his partner trying to hang himself in the garage. So whatever you get it in the history or in your stem, then you just add it here. So you give a brief introduction about this patient, and then you give your MSc presentation. So first is, how about the appearance and behavior of the patient? So appearance and behavior has this 5 or 6 point that you should look into a patient. And this is the most important aspect of your MSc presentation. It shows that if you are looking at a patient correctly, if you know what the patient is trying to show you. So first you look that if the patient is dressed appropriate to the weather or not, if he is well groomed or unkempt, if he is cooperative or not, if he is maintaining eye contact or not, if you can see any abnormal body movement or posture. Some of the abnormal body movement or posture might be like patient with depression will, most of the time they will sit leaning forward like stooped posture. Anxious patient will have frequent fidgeting of their hands, restless in nature. Mania patient will be very loud, talkative, restless, and agitated. And schizophrenia patient will be distracted. And sometimes, if you are very careful, you might be able to notice that they're looking at the ceiling or they're looking at somewhere around the room as if they can hear someone talking to them. So that's called distracted and seems to be responding to some unseen or internal stimuli. So sometimes in schizophrenia patient, you can, if the patient is looking at the ceiling, you can comment in here that patient was distracted and seems to be responding to some unseen stimuli. So appearance and behavior, these are the things that you will comment on. So is he dressed appropriate, well groomed, cooperative, maintaining eye contact or not? And if there is any abnormal body movement or posture. After A, then there is speech. In the speech, what you look for? You look for if the speech is normal in tone, volume, and rate. So three things that you comment on: rate, volume, and tone. Most of the patient, if they are talking like a normal person, their rate, volume, tone will be normal. But a patient who is depressed, they will not sound normal. So most of them will be very slow and monotonous. Monotonous means that just one word at a time. If you ask that, how is everything going on, John? They will say, yeah, um, okay. So see that very slow, monotonous, that's how they usually talk. So slow and monotonous depression. On the other hand, mania patient will be very rapid and pressured. So rapid pressured speech suggests possibility of mania. You can also find some other finding in a depressed patient, like they are taking lot of pauses in between. Mania patient will not answer your question appropriately. They will just talk and talk. In psychotic patient, you can get a disorganized speech also. So these are the things you can find out. Whatever you will find out, you will give commentary to the examiner in that way. So that's your speech. If it is normal in rate, volume, and tone. After you have done the speech, then is emotion. Emotion has two parts, mood and affect. Mood means if you ask a patient, how is your mood? If patients say low, that's mood. But if you see if you look at the patient and you see that patient looks happy, that means the affect that you have observed is not congruent with his mood. So affect means what examiner looks into a patient, and mood means what patient says about their mood. All right, like a psychotic patient, if you ask that how is your mood and he says all right, but if a psychotic patient's mood cannot be all right because they are very disturbed. Okay, So you have to say and at that time that according to the patient, his mood is all right, but the affect that I have observed is disturbed and not congruent with his mood. But if you see a patient saying that his mood is low and he looks very gloomy, crying in front of you, then you can say, yes, the affect that I have observed is congruent with his mood. So speech and emotion is done, then is perception. So remember I told you perception is the hallucination. So you talk about what whatever perceptual disturbance you have got from the patient. So have you got any auditory, visual or tactile hallucination? So that's perception. After perception, we have thought form and thought content. This is the area people get confused a lot because they think they just make a confusion between thought form and thought content. Remember, thought content is the delusion, and thought form is if you are able to understand what patient is saying. If you can understand patients talking, and if they're answering you correctly, spontaneously, that means that patient's thought form is linear. Linear thought form is normal thought form. Okay. So linear thought form is the normal thought form. That means if a patient is giving your questions answer appropriately. But there are some abnormal thought form that you can get in schizophrenia patient or mania patient. So in schizophrenia patient, you can get loosening of association, you can get tangentiality and circumstantiality, you can get concrete thinking. So all of these findings can be there in a schizo patient. But schizophrenia patient can have a linear thought form also, because most of the time in exam they will give you someone who is able to answer you, right? So very unlikely you will get someone with tangentiality, circumstantiality in a exam. Flight of ideas, that's another abnormal thought form which can be found in mania patient. Now these two can get quite confusing. What is flight of ideas and what is this loosening of association? In a sense, loosening of association has two subtypes. That is your tangentiality and circumstantiality. So what this loosening of association and flight of ideas means? Let me give you some example of this and you will understand. So loosening of association means there is no association on of anything that patient is saying. So every sentence patient is saying, the next sentence does not have any association. It's like if I ask a patient that, how was your morning today? And patient says, oh, okay. When did you buy this dress? It's a lovely evening. I should go for a walk. I feel like having a chocolate. No, oh, I need to study for the exam. I went to the market. That movie has a very good reviews. Yes, I went there by bus. That car was really looking nice. So if the patient talk and talk but never answered your question, what did you do in the morning? That's tangentiality. But if somehow during all this jabbering, the patient says that yes, in the morning I have my breakfast and I went to the market, that means that's most likely circumstantiality. Circum means circle, right? So circumstantiality means that you ask a question here and patient talks a lot and lot, making no sense, but at the end answer your question. That's also a loosening of association. But in tangentiality, they just talk and talk and talk without any association between each sentence that they are talking about. And they never answer your question. Both of them is a part of loosening of association. One is circumstantiality, which eventually answer your question, but tangentiality, they don't. All right. Whereas the flight of ideas that you can find in a mania patient, there each sentence has a little bit of association. Still, it does not make too much sense, but each sentence have association. So, like this one, you ask a patient, "What did you do last night?" Patient say, "Yes, oh, I watched a movie. I love that movie. I'm going to watch a movie with my mom. My mom adores me." So what's happening? They're jumping from one conversation to other with a little bit of association. So I loved that movie. I am going to watch a movie with my mom. My mom adores me. So none like I love that movie. She could have talked a little bit about that movie, right? But she just jumped into the next thing, which is I am going to watch a movie with my mom. She could talk about this movie, that what movie she wants to watch with the mom. Rather than that, she went into another conversation like my mom adores me. When a patient jumps like this from one conversation to other and having a little bit of association in between, that's what we call as flight of ideas. Like if you see here, my mother is very sweet, but she is always getting angry at me. I never get angry because I love everyone, but only my dog loves me. Dogs are man's best friend. Friends can become enemies. That man is the enemy of the nation. Now you can see how much jumping is there. So that's called flight of ideas, which means jumping from one thing to another, making a little bit of association in between each sentence. Is this understandable, guys? And then there is concrete thinking, which also you can find in a schizo patient. Concrete thinking means that when you ask a question, their response is very literal response. Like, how do you feel? And patients say, I feel with my fingers and toes. So, so that's a example of concrete thinking. So those are the things that you will be looking for in a thought form. So someone asked about affect, right? So affect means that what you see in a person. That means that if examiner also think that this patient's mood is low and patient says, yes, my mood is very low, that means the affect is congruent with his mood. So mood means what a patient says about their mood, and affect means what you as an examiner observe in a patient. So a patient saying my mood is very low, and you can see that patient looks very gloomy, crying in front of you, then yes, the affect that you have observed, that's congruent with his mood. So once you have done the thought form, next is thought content. The thought content has mainly delusions. Apart from that, some overvalued ideas and obsessions. So delusion already you have got an idea that those are the delusions that you can get in thought content. In terms of overvalued ideas, patients with eating disorder like anorexia nervosa, bulimia nervosa patient, they will think that they have some abnormal perception about their body weight and shape. They feel that they are very overweight, and for that they start doing crash dieting, self-starvation, lots of vigorous exercise. So that's called overvalued ideas. That means if they feel that they are overweight, but actually they are not, and then they start doing all those restrictive activities, that's overvalued ideas. That's also the part of thought content. And you all of you know what is OCD. So obsessional thoughts also falls under thought content. Okay. So delusion, overvalued ideas, and obsessional thoughts, these are all part of thought content. After that, we move on into cognition, judgment, and insight. So, cognition explain that if the patient is oriented to time, place, and person, usually delirium patient will not be oriented. Sometimes schizophrenia patient also can be quite disoriented. Talk about if the insight is intact, if the judgment is intact, and then lastly talk about 3R. So risk of the patient. So if the patient having homicidal or suicidal thoughts, that's a high risk patient. If a patient having active hallucination or active delusion, that's a high risk patient. But if a patient having like no suicidal thought, no homicidal thought, and no hallucination delusion, that patient is a low risk patient. So in terms of what you get in your history, you just say that if your patient is a high risk or low risk patient. Then there is rapport. Rapport means that are you able to maintain a good rapport or relationship with the patient throughout this conversation? Now, it's not your fault if the patient was not answering your questions properly. That patient is designed to be like that. But if a patient talks to you nicely, answer your questions, then you can say that you are able to make a good rapport with the patient. But let's say a manic patient obviously will not answer your questions. In that case, you will say that you are not able to maintain a good rapport with the patient. And then there is reliability. If the history that was given by the patient was reliable or not. Reliability depends if a patient has no insight, if a patient is having active schizophrenia or psychosis, their history is not reliable, which means you will have to ask a collateral history from, from someone who is accompanying this patient. Maybe a family member, maybe some friend, neighbor, or maybe a police officer who brought this patient from the street. All right. So reliability, also a patient who is having active suicidal thought, their history might not be reliable. So that's how you present MSc to an examiner. Now I'm going to show you actually how you will do that in an exam. So let's say that you have done your history. Now you're going to present MSc to the examiner. Let's say that our patient is depressed patient. Okay. So how we are going to explain it to the examiner? So we'll say that, dear examiner, I would like to present the mental state examination of my patient Mike, a 35-year-old doctor found by his partner trying to hang himself in the garage. In terms of his appearance and behavior, he is dressed appropriate to the weather. He looks well groomed and was cooperative, but he was not maintaining eye contact throughout the conversation. He was also sitting as a stooped posture, but he does not seem like distracted, and also there was no fidgeting, restless behavior. So sometimes you also give negative comment. In terms of his speech, he was very slow and monotonous, but there was no disorganized speech or rapid pressured speech. His mood was low, and the effect that I have observed also congruent with his mood. In terms of perception, there was no auditory, visual, or tactile hallucination. His thought form was linear. There was no loosening of association or flight of ideas. In terms of thought content, he had delusion of guilt, but no delusion of control, reference, paranoid delusion, or delusion of grandiosity. He was oriented to time, place, and person. His insight was poor and judgment was not intact. In terms of risk assessment, he is a high risk patient because of active suicidal thought and active delusion. I was able to maintain a good rapport with my patient, but the history he has given was not reliable to me. So I would like to ask a collateral history from one of the family member. Okay. Now, reliability for a depression patient, you can say that it's a reliable history, even if the patient having very suicidal thoughts. But for a schizophrenia patient or mania patient, we would say that history is not reliable. There will be no one in the room, not no family member or anyone. You just say. A lot of time you will have to just act in the exam. There will be no one. These patients are not real patients, they are simulated patients, but they are better than real patients. Okay, trust me, their acting is even better than a real patient. So you'll never even think or get any clue that this is not a real patient. Now, someone of you asked about concrete thinking. Concrete thinking means like if you don't understand a joke, right? That's concrete thinking. If you don't, if you're like that example that we have given, that how do you feel? If that question was asked to you, what would you say? You would say, yeah, I'm feeling fine or I'm feeling low. But that patient said, I feel with my toes and foot. That's actually how they think. Their thinking is very constrictive. So, will there be videos? There are some video MSc cases, yes. So, some we will discuss some of the MSc video case. We will do some role play on that, so you will know how it happens. Now, the question Dr. Ajay has asked that when we will do examination, is there any chance that examiner would ask in between that why you are doing this? It is very rarely they do it. I would say very unlikely, but it doesn't mean that they don't. In very rare cases, sometimes they can ask you that, like, you are saying that I'm going to give you some antibiotic to you. Examiner can ask you what antibiotic you are going to give. That kind of thing, they can do it, but not very common. All right. So that's your aseptic J3R, guys. Is there any question? So let's give a summary of what we have discussed so far. So this is your MSc format. So now you should have an idea that how this case works. Like let's say someone came to you because wife brought the patient because wife found that this patient was trying to hang himself in the garage. Your task is to take a psychosocial history from the patient and present MSc to the examiner. So you'll take the history like we have done, and then you'll go for your MSc presentation. And in MSc presentation, you will follow this aseptic J3R and you will give this presentation to the examiner exactly how I have shown you. If you do that, there is no examiner there who can fail you. All right. Any question? Now let's take a 10-minute break and just keep thinking in your head that how you're going to do this case. And I will keep this aseptic J3 or this one in here so that you can just think about it. After we have done our 10-minute break, we will do some cases. And any of you are welcome to participate in the role play. So we might just go do one role play with you today, and then the next class on 30th November, we will do a MSc role play class. And on that class, we will do almost all MSc cases that is important for your exam. Okay. So let's take a 10-minute break and then we will start with some cages. Thank you. All right, guys, let's start. Before I start, do you guys have any question so far about the MSc? And those who are in the Facebook, you guys, do you guys have any questions? You can always write it in the chat box of over there, and I can always have a look. You guys have any? Just write it in the chat box of over there. All right. So let's start. No, very unlikely, Dr. Shiravi, that patient of schizophrenia will have any guilt because they don't have any insight. So unlikely that they will show any kind of guilt. And once we join the course, do we have to tell whether we are appearing online or face to face? No need. So if you are not sure, it's fine. And yes, the physical examination will be taught in both format. We'll come to the course detail, Dr. Shirina. So just wait for that and you will get all of your questions answered. Okay. Now, let's just go through this one. Like we already aware of this case, I think, from our discussion. So a nurse is brought by his wife as he was trying to hang himself with a rope since a patient died during his care. So this one we already have done just now, so it should be fine. But we will do a role play during our role play session. Now, I think I will just do one role play today with you. So if any of you are like wanting to do any role play, especially if you are already you're prepared or you're preparing at the moment in the middle of your preparation or going for the exam very soon, you guys just can come and do the role play. Anyone interested? Yes. So Dr. Rao, you want to do it? All right. Just give me a second. I'll give you the case and I will also unmute you. Dr. Rao, can you hear me? I can't hear you, unfortunately. Yeah, I think I just heard a little bit of noise. Can you say something?
नहीं हो रहा. Hello, Dr. Shan. Can you hear me?
Yes, I can hear you now. How are you, Dr. Rao?
मैं कह देती हूँ, there is problem.
You can hear me or not? I could hear you.
Mic.
ये होता है ना mic.
MIC.
Your mic is fine. I think I can't do this now. Okay. All right, it's fine. Is there anyone else who wants to do a role play? No one? That's strange. Yes, Dr. Rashmi, you can. It's really fine. Okay, let me unmute you.
Hello.
Yeah. Hello, Dr. Rashmi. How are you?
Thank you. Thank you. How are you, Dr. Asha?
I am good. Your sound is little bit of like coming from very far. If
Uh,
you can, yeah.
now, can you hear me?
Yes, I can hear you now. That's good. Perfect. All right. So you're ready for the role play?
Yeah, let's try.
Yeah, good. So that's really good that you are coming. And like if you can do it in front of 50 people, you're good. No problem in your exam. Okay. So what we are going to do is to do this role play as part of like a just a exam in. So in exam you get 2 minutes outside, 8 minutes inside, but we will try with 7 minute 30 second because that's usually how you should be prepared.
Okay.
All right. So this is your cue.
Mhm.
Your 2 minute time just started.
Okay.
All right, you're ready?
Yes, Doctor.
Okay, so this is your patient. Your patient name is Sam. You can start.
Okay. Hello, Sam. I'm Rashmi of the doctors over here. How can I help you today?
There is no need of any help. Just let me out because this is a filthy room, doctor. It's all over. There is cockroaches. It's
All
just
right.
crawling all over my body. Just let me out of this hospital. This is a filthy hospital. I should not come here.
I'm so sorry for that. I'm extremely sorry, Sam. I'll make sure that this room is cleaned for you, and or else I can arrange another room for you. I'll get the cleaners in for this situation. And
There's a cockroach on my hand. Bloody cockroach, just go away. Just leave me alone.
Oh, we'll get this clean, Sam, for you. And meanwhile, is there anything that bothers you that makes you, any pain or anything?
Yes, this cockroach is the pain in my ass. It just is making me crazy right now. Can you ask that cleaner to come faster? I just
Yes,
can't stay
sure.
here anymore.
Sure, I'll make
Oh,
sure to do
there
that.
is a cockroach on your shoulder, doctor.
Oh,
Just
okay. All right. Yeah, I'll take it off as well. And Sam, do you, apart from seeing cockroaches, do you hear anybody, or do you do you see that someone is telling you something or anything like that?
no, there is not. Do you think I'm crazy, doctor? I'm not crazy. You can also see the cockroaches.
Yeah, it's not that you're crazy, Sam. I'm just questioning because there's some questions I'll have to ask you, like which I ask from each and every my patient. Okay, is it okay with you?
Yeah.
All right, Sam. And also, there are some other questions which I will be asking you. You might feel that they are somewhat different, but it's just questions which I ask from each and every patient. Okay.
Okay.
Yeah. All right. So, Sam, do you think that 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 someone is spying on you, or someone is you know waiting to harm you?
No, I don't think so. But these cockroaches, obviously, they are here for some reason.
Mm-hmm. Yeah, okay, okay. We'll get rid of this, Sam, immediately. Okay. And meanwhile, also, do you feel that that you're that you do you feel any guilt for any reason?
I feel guilty because I was in this hospital. I should never come to this hospital where there is a cockroach. How come a hospital has cockroach like this?
I'm
We are the
so sorry.
patient. We are not animals in here.
Yeah, I understand. I understand that. I agree with you, Sam. And also, do you feel that your thoughts are being broadcasted in the TV or in the paper at some times?
No,
Or do you feel that your thoughts are being inserted, that some thoughts are being inserted into you, or your thoughts are being withdrawn by you by someone?
no,
Okay. And also, Sam, do you feel that do you need some medical help?
not a medical help, but I obviously need some cleaner help, or I just want to go out.
Yes,
I already
yes,
have my
yes.
operation.
I agree
I'm
with
done
you.
with this.
I agree. I agree with you. I agree with you. How about your operation? Do you feel okay with it? Any pain there?
No, I'm fine. I just want to go out of this bloody hospital.
I understand. And Sam, what if there's a fire over here? What will you do?
There is a fire in this room. Oh my God, there is cockroach and now there is fire.
No, I mean, I'm just asking if there is a fire. It's not that if there is, but if there is fire, what will you do?
I will just run out.
Yeah, that's great. And also, um, are you taking any medication for any other condition, like any long-term condition?
No.
No. So why was this surgery done for you?
Yeah, I had a dislocated shoulder.
Mm-hmm. And apart from that, how about your daily activities? It seems that you've been, like from your notes, I understand that you've taken, used to take some alcohol.
Yeah, I do.
Mm-hmm. And when did you have last?
4 days ago.
Mm-hmm. And do you feel any shakiness, any jitteriness?
Yeah, I feel.
Mm-hmm. And anything else that you are having any complaint you're having?
No, I just want to go out, doctor. Just let me go out. It just the cleaner was never going to come here. I know because I have asked multiple times. No one
Mm-hmm.
even cares about it. So this hospital, I'm done with. I just need to go out of it. It's not going to help.
I understand. I understand your concern, Sam. I'll make sure that I'll just check and see where the cleaner is, and we'll get the things done quickly. And we'll get some medication for you for your surgery. We'll complete the medication, and then we'll see how it's it for you to go. Okay.
Okay.
And all right. So anything yeah. So that's yeah. So Sam, I'll get back to you after I talk to my examiner. I'll get back to you, okay?
Okay.
So the examiner, Sam, who's a 47-year-old patient who has had a surgery a day back, complains of seeing cockroaches, of visual hallucination, and the patient appears patient is dressed according to the weather, and speech is kind of a pressured speech, and also emotion wise, patient is quite aggressive, and also in thought form, of course, the patient is, according to the like is linear in yeah, in thought form. That I'm not quite sure about, and um, and patient is not having a proper insight, and also judgment wise, yeah, patient is okay with the judgment. I couldn't ask about cognition, and uh, yeah, about risk. I couldn't, I don't see any. Yeah,
Time up.
yeah. Okay.
That's fine, Dr. Reshmi. So you did really good. I'm really happy with your approach mainly, how you did, how you managed to do this case. That's actually important. This is one of the case which make candidate crazy in the hall. So you
Mhm.
did lose it. That's the most important part. Okay.
Mhm.
So I feel like the initial approach thing was nice. Your history was also very good, but because of the pressure, you just like forgot the initial thing. Okay,
Mhm.
like
Mhm.
mood, sleep, appetite, suicidal risk.
Yeah,
Those
yeah.
things are important. You can ask it. Sleep appetite is not even a part of MSc, so even if you don't ask it, it's fine. But mood is very important. Suicidal risk is very important.
Yes, that I missed. Yes,
Yeah. And obviously, the first thing is that you haven't given any confidentiality.
confidentiality.
Yeah.
Yes.
So that's the most important thing that if
Mhm.
sometimes what I'm going to do, Dr. Rashmi, is to just mute you because there is a echo coming out and then I'll talk to you later on. Okay. So what's happening here that if you don't give confidentiality in the exam, there is a chance that the role player will not even answer anything properly. So they can just give you city answer and you will not even get anything from them. So that's permitted in the exam that if you don't give confidentiality, they can do that with you. So confidentiality statement is must. And there are some cases where candidates just like wheel around them, but never ever got any appropriate answer from that because they did not give confidentiality. So confidentiality in a psychiatry is must, never to forget that kind of thing. So that's why I always say that remember to give confidentiality if it is needed. So apart from that, you did everything nice and good. And so in MSc presentation, if you are running out of time, don't bother too much about some other history like smoking, alcohol. Even you don't need to ask the heads because that's not even part of your MSc presentation. So that's a cool thing to do that if you think that you're running out of time, just ask questions related to aseptic J3R. Once you are done, you are good because you just need to give those information to the examiner. So in case of your aseptic J3R, obviously you can't talk about appearance because you can't see the patient now. But speech, yes, you can say it was a little bit pressured. Then in case of emotion, you did not actually ask the patient about the mood. So the good thing would be that if you forget something in the exam, just say that you did not assess it by mistake. If you say that you did not assess it, they are happy. But if you say that you have assessed it, but actually you did not, that's the thing which examiner does not like. All right. So just say that I did not assess my patient's mood, but the effect that I have observed seems to me that it was disturbed. If you say something like that, you will not lose any mark. You did not say about perception because that was the most important part here. That means the patient was having visual and tactile hallucination because he could feel the cockroaches crawling on his body, and obviously he can also see the cockroaches. So visual and tactile hallucination is the most important finding here. After perception, we have thought form and thought content, right? So thought form was linear in here because patient was answering your question appropriately. So you can say it's linear. Then thought content, patient did not have any delusion. Insight was not intact because patient says he did not need any medical help. Cognition, again, you did not assess it, and you said that you did not assess it, so that was good. Judgment was good because he said that he would run away. Then, in terms of risk assessment, this patient is high risk because of active hallucination. Okay, you can, if no suicidal thought, you can even say moderate to high risk in here. Then you were able to make a good rapport with the patient, and obviously the history is not reliable because it's a psychotic patient. So you need to take a collateral history from the nurses. Okay, because in here patient is in the surgical ward, collateral history would be good from a nurse. Okay, so that should be your MSc presentation in this case. But you did really good. I liked your approach. I liked how you talked with the patient. That matters a lot. Yeah, now if they ask you, like if this question was also about diagnosis, our first diagnosis could be like it's a delirium due to alcohol withdrawal. That will be the first diagnosis. All right. But in MSc presentation, you don't need to give diagnosis unless they ask it to you. So psychosocial history is needed, but not the whole psychosocial history. Like your psychosocial history had heads, SADMA, those things not needed. If your task is just present mental status examination to the examiner. But if you can ask it, that should be good because then it shows that you are taking appropriate history. But if you're running out of time and you did not finish your MSc presentation, then you will fail the case eventually. So it depends how much time you are having in the exam. If you could finish the whole psychosocial history and also finish the MSc presentation, you're fine. But most of the time it does not happen because you can see that it's like the role player will interrupt a lot and you will lose time, you will feel nervous in these cases. So even if you don't ask head sadma, that you should be fine. Collateral history is usually from someone who is not having enough insight and who is actively hallucinating or having any active delusion. Those patients, you'll need to ask like those everything that they're saying, it might not be reliable, right? So you need to ask it from someone else. So usually for a schizophrenia patient is must, mania patient is must, but for depression patient, usually their history is reliable. Okay, now so this will be our tonight's role play sessions or tonight discussion about MSc. We will not go much further than this because we have one class just on doing role play on these MSc cases. So we'll do that in that case, in that class. So I would be able to, like you would be able to unmute yourself and ask questions. But before you do that, I would just like to show you the course detail a little bit so that you understand and then ask questions if you have any question. And Dr. Ajay, so your question is step by, I would I would go for a step by step approach. But how Dr. Reshmi has done, because patient was actively hallucinating. Like I started that I can see cockroaches. So she started with the hallucination or perception question first. Then she did the delusion question, and then she should go back to the mood, sleep, appetite, suicidal risk, then insight, cognition, judgment. So if you do in that way, that's also very good because you are just focusing on the presenting complaint. So you can play around the format, but as long as you have the format in your head. All right, cool. Now let me show you the course video so that you have an idea about the course and then we can go from there. Okay, just give me 1 second. So let's have a look to this video. This should give you the whole idea about the course. And eventually, if you have any question, just ask me. All right. So as you can see, so that's the course duration and everything is given in here. And if you actually had looked into it, you could see that it has almost everything that you need for passing your clinical exam. I can't say enough that throughout the year, we have made it in a way, we have collections of everything. Like, I don't think there is any course in here who has the collection like ours. So it's been over 5, 6 years now. So throughout these years, we have collected things. We have the role play videos of almost every course of every cases that can be important. So nothing is much important than that. So if you go through the course detail, you can see that you're going to get 2 weeks free session from 30th of November. Before that, there will be a session on all the APRA registration, job searching, and everything else. After that 2 week session is done, then you will get your orientation session, and the classes happens 3 days in a week. Currently, it's Saturday, Sunday, and Wednesday. Usually, it starts from 8 or 8:30 p.m. Sydney time, and class duration are 2 hours or sometimes 2 hour 30 minutes. It's a 5 months course, but most of the time we are able to finish the course in 4 months, 4 months, 1 or 2 weeks, you can say. So usually we are able to finish the course quite early, but we just keep the 5 months. So in case there is something needed or we had some issue, then we could finish it in 5 months time. If any of you are appearing in exam in few months time, like you have already got your exam for March or April, then we have also options so that you can finish it in 2 3 months. So we always add you in our previous coach batch recording, so that you get all the videos, all the recorded classes, and you can just go through everything that we have done. And in that way you can finish your course in 2 3 months. On the other hand, you can also continue joining our live session with the new batch that you have joined with. So there is a way to finish it in 2 3 months also if you want to do it. The classes are divided in this way that we take theory sessions based on clusters. When we will have our first 2 week session, you will get a cardiology cluster with us, and you will see how the cluster wise approach works. We also do role play on those clusters. So if we are doing a cardiology syncope cluster, we will have role play on that, and you will understand how to do role play based on those clusters only. Just like we have done a role play today, but there will be just a separate class on each of those clusters. One class every day, which will be taken by Dr. Cynthia, who is an excellent doctor who also working in here in Australia. So she will also take one role play sessions based on the recent important cases. So, and also you will get, so far we have taken 75 role play sessions. And as a new batch, you will get all those 75 videos of role play classes, which has almost 150 above cases. So you can go through those recorded sessions as well to get some idea about the questions. You will also get all the notes until you pass the exam, and a video recording access will be there for a prolonged time, even after course is finished. So you can go in your own pace and just appear the exam in your own time. Okay, so that's pretty much everything. And there are some other details that you can find it in our website also. So if you go through there, you will get a very extensive idea about it. This is one of the most cost-effective course that you will ever come across. And I can't say enough that it is how beneficial it is for IMGs who are struggling to get into the system. All right. So if you're actually looking for something as a whole, there is nothing better than this. That I can assure you. For appearing the exam, it's a whole personal thing, because maybe you are getting a lot of time to appear the exam, but maybe someone else is here who have to work in hospital 10 hours in a day, and then they come at home, they have their family, so you might not be getting enough time to study. So for you it's totally different that how much time you will need. But if you can give your time to study at least 6 hours in a day, then you can appear the exam in 5 to 6 months. Okay. But throughout my experience, I have seen that usually if you keep 6 to 8 months time, that's the best time. So if you can keep that 6 to 8 months and give a consistent steady time during that period, you will be fine for the exam. Yes, all the classes will be after work because we also work in Australia, so we can't take classes in morning. Like there might be some courses where there are mentors who don't work in Australia or anywhere, so they might be able to take morning classes, but we can't because all of our mentors working in here, and we just like even it sometimes become difficult, but we do it. So we do all of our classes will be after hours. Okay, which means usually around this time. But if you can't join the classes, the recordings will be available next day. You can always go through it. To to admit into the course, you just need to either you email to us. So email ID is already given in the Facebook group. So you either email to us or just send me an inbox. So if you are in our first aid AMC clinical Facebook group, you can see all my posts. So you can always just inbox me that you want to admit into the course. Then we will ask you some questions and then we will go from there. No, you don't need 2 to 3 times to pass the exam. That's where we are here because if you need 3 times to pass the exam, then whatever we are doing is not right. Okay. So most of our students are able to pass the exam in their first attempt. If not, then obviously by second attempt. You can, yes, these classes will be counted as CPD, but you will have to add these CPD hours in your college's dashboard. In our orientation session, we will show you how to add those things. Now, Dr. Ajay, I can't answer that question that will you be able to pass exam in April? Because that's a whole different thing, right? Your pass depends on how much hard work you are doing. It's not about like if you just do the course, you will pass this exam. You will have to do your hard work. You will have to do role play. If you do everything right, yes, there is a chance that you can pass the exam. But I would not be very like if December to April, just 5 months. I would ask you guys to keep at least 6 months because once 5 months course is over, then 1 month just keep it for a revision and then take the exam date. Okay, I think before taking the exam date, you should start your preparation, find out where are you at the moment, then take the exam date. Okay, the course is Saturday, Sunday, and Wednesday. Most, yes, the role plays in a class. Usually, we try to cover almost all cases that is important. So I do the role play. Dr. Cynthia does the role play. So we have like a lot of role play sessions throughout the course, like a lot. So, and many of the candidates does not want to do role play. So if you actually want to do the role play, you have a lot of chance to do it. So you could see today even when I asked someone to do a role play, there was only 2 people. So that's what happens in real case also. We don't get enough people to do role play because I don't know like why. Maybe they are shy or something, but we always try our best to add new people to do the role play, and we try to motivate you to do the role play so that you don't feel just. And everyone, when you join the course, you meet new people, you make new friends, and you become comfortable with them in few months time. So that's why one of my suggestion is that please don't think that you can pass this exam in 2 to 3 months. If someone is saying that in your face, they're obviously misguiding you. It's not that easy that if you could pass it in 2 to 3 months, a lot of people would pass it. Trust me. It's not about like you are not knowledgeable. You are knowledgeable, but the preparation is vast. You have to go through a lot of things, so which it's very hard to finish in 2 3 months. So please don't think in that way, and please don't listen to those people who are misguiding you. It's not actually a good thing to be done. Okay, even if like just to get acquainted with this whole new things, it takes 1 to 2 months. The reason why we take it 5 months, that's the main thing, because by the time you finish 2 months with us, you become a pro. And then you start asking questions like you are actually in the right path. All right. And let's say you are doing a course which is 2 months, 3 months duration. By the time you start asking question, that course is already finished. And you will not have anyone to ask any questions. So that's why we do it as a 5 months. If we could finish it in 2 3 months, and then there will be a lot of like more courses that will be more beneficial. But we never do that. In 1 year, we have only 2 courses, but that 2 courses that we take it really seriously. That's the reason why our candidates pass, because it's not about just taking a lot of courses and not giving them enough time. We give enough time to the candidates so that you know what you are doing, and you when you go and appear the exam, the examiners know that this candidate has things to pass this exam. All right, so those are important things, guys. So if you don't have the confidence in yourself, your tone, your movement will show to the examiner that no, this guy is not well prepared. The case renewed, yes. Recorded classes will be in your portal. So when you join the course, you get a subscription to our portal, and our portal has everything. If you had looked into the video, you could see that some of the portal things. So you have all the recorded classes, notes, everything in the portal, so you can access from there. 2 weeks free session means that we will take classes and anyone can join those 2 week sessions. So why we do that is that anyone can take one class or even two class, and that will be very fantastic, like wonderful class. And you might fall into a trap, knowing that well, like he's really doing good, but no one can pretend to take good class for 2 weeks. So we give you that opportunity to find out that if this course is beneficial for you or not. And if you actually feel that yes, this is beneficial, then only you join. Otherwise, you don't join. So that's why 2 weeks free session is there. But that 2 weeks free session is included in your course, which means you will take the classes just like a regular class, and you will get to see how we take the class. Now, the good thing when you join such a course is that you meet a lot of people, and you will always find someone to do role play practice with you. All right. So there is no problem with that. And we also help you to get someone. So you will find someone to do role play. Yeah, the tonight session will be available in Facebook, also will be available in YouTube. So if you want to go through it, just you can go through from the Facebook, or tomorrow I will also upload it in the YouTube. The link will be given in your Facebook. So you can go through that YouTube. Okay. Yes, Dr. Mikala. So you have a class on Sunday also. So Saturday, Sunday, and Wednesday. All right, guys. So it's very nice to meet all of you. I hope that we will see again that you are joining the next class, and keep an eye on the Facebook, because everything is usually getting updated in the Facebook right now. So you will get all the classes schedules, everything on the Facebook for the free 2 week session, and also the session on 26th where we are going to discuss the registration pathways. It's very, very important. We take those sessions twice in a year, but trust me, you will learn a lot. Okay, so that should be all for tonight, and thank you so much for joining. Have a very good night. Take care. Bye.